Fawzia sheet started from question 41. I just share the screen. Okay, you see the question now or not?
Yes, Prof, can see.
Okay, all right. Of course, again, if you found any question, you don't found the answer is proper, just tell me. So 44, we started now today from 41. So 20 years man present to the emergency department after accidentally trapped over lacerated his hand on a glass bottle. On examination, there is 2 centimeter laceration on the hypocenar eminence and the loss of flexion in the distal interpharyngeal joint of the little finger. What is the most likely tendon to be injured? So this question, he need to ask what is the tendon inserted in the distal interpharyngeal joint. Of course, distally, they have flexor, but which flexor? Anyone have an answer? The
Yes, profundus.
Yes, flexor digitorum profundus. By the way, we don't have flexor digiti minimi brevis, it's just flexor digiti minimi. I pick it. All right. Next question. 75 years old man, chronic smoker. Usually chronic smoker, we looking for respiratory acidosis and all this. Underwent coronary artery bypass, grafting 6 months ago. Left internal mammary artery used as a grafting. Nowadays, we don't use saphenous, we use internal mammary after ligated the intercostal branch. He is now complaining of angina on mild exercise. Which lesion best explain this symptom? Of course, again, we know that the internal mammary is branched from subclavian. And we take it, we don't cut it from subclavian, we leave it attached to subclavian. We just take the distal to be inserted in the heart. In the answer sheet, I put a picture for that. So if the patient have angina due to any effort, so most probably it is stenosis in subclavian. But at which level? It is distal or proximal to the first branch. Anyone have an idea? Okay, so it is a stenosis of subclavian artery, proximal mean before the first branch. Okay. I just I can show you the picture. Maybe you have it here, 42. Because sometimes it's difficult to imagine. Okay. I share again the picture. This is what happened nowadays in coronary. Nowadays, this is the arch of aorta, this is subclavian. The internal mammary is one of the branch of first part of subclavian. We take it and insert it in the heart, mimic coronary. So it is artery, coronary is artery, instead of taking long saphenous vein or any other structure. So suppose this patient have pain due to any exercise, so most probably they have stenosis before here, so it is proximal to the branch of internal mammary artery. So you got the point, you can imagine what is the anatomy used now. Okay, it is clear. It's very common question. Of course, internal mammary have a branch, what we call that intercostal branch, we already ligated. Okay, this is the explanation. So back again to normal question. Next question. is about 50 years old, alcoholic man presented to emergency and found to unable to extend his wrist, thumb, fingers. Usually extensor is supplied by branches of the posterior cord, which is radial and posterior interosseous. Is also found to have weak in extension of the right elbow and joint and loss of sensation of the dorsum of the first rib. Which nerve is most likely being injured? This is easy question, and it is what he need to explain to you. He have loss of sensation in this area, what we called it first whip. So if you have loss of sensation in this area alone, it indicate which nerve. Anyone? Y- yes, it is indicated the radial nerve. Okay. Next question, and again, it is about dermatome and the myotome, and which is important. A 55-old man presented with acute back pain following severe RTA. Neurological examination revealed lack of dorsiflexion of the left ankle joint, dorsiflexion of the ankle. Which of the following spinal cord segment most likely to be injured? So, dorsiflexion of the left ankle, it is L4 and 5. Plantar friction S1 and 2. So this patient have lack of dorsiflexion, so L4 and 5. Of course, if you found this area of the ankle is also supplied by S1 as dermatome, so the answer is L4, L5, S1. So it is important again to remember dermatome and myotome. Next question is repeated many times. 21 years old man admit to emergency with stab wound in his right chest. Pulse rate is 100 beat per minute. Blood pressure 85/40. Low chest X-ray show right pneumothorax. Which is the first substance? So apart from the scenario, he asks you something different. What is the first substance secreted increased renal reabsorption, sodium in the response of trauma? So again, we mentioned it is renin, angiotensin, aldosterone system. So the first substance will be renin. Next question is 21 years old man has been stabbed in back of the knee, divided popliteal artery, and undergo repair via posterior approach. Which of the following structure is most likely to encounter first when dissected the deep from the skin incision? This is a tricky question and very common, because what happened, usually anatomical position is like that. So the popliteal fossa posterior, but when you need to excise or make incision in popliteal fossa, you make the patient in prone position, which is against the anatomical position. So now he asks you, what is the first structure? What is the first structure dissected deep of the skin incision? So after skin, you can find here. So if you found this picture, what is the first structure after the skin?
Tibial nerve.
Anyone? Tibial nerve. So tibial nerve is the first structure. We don't consider it as anterior. It is still posterior, but it is superficial. If you asked from anatomical position, what is the anterior structure in popliteal fossa, the answer is popliteal artery, because although it is more deep, but it is anterior from anatomical point of view. Tibial is superficial, but it is posterior from anatomical point of view. Okay, so the answer here, the first structure is tibial nerve. We can find many questions about this, like is the patient have ruptured tendon? What is the lateral muscle? It is biceps tendon or biceps femoris injury. What is the lateral nerve? Is common peroneal nerve. Next question is about 78 years old woman presented. Okay. So 78 years old woman presented with urinary urgency and incontinence. External urethral sphincter is innervated by which of the following nerve roots? So he asked about, is the patient have urine incontinence even fecal incontinence, which nerve is injured. Of course, it is within the nerve, but here he asked about root value. So anyone know what is the root value of within the nerve?
S2, S3, S4.
Okay, 2, 3, 4, S. So this is the answer. Okay. All right. Next question. 48 is about 40 years old woman presented with a parotid tumor, a biopsy referred pre-neural invasion, which most likely pathology. This question is common, and again, as we mentioned before, in the MRCS exam, it is combined between general surgery and ENT or otolaryngology. Usually, any cancer in the parotid can invading the facial nerve, but the commonest cancer can invaded or characterized by pre-neural invasion is only one of them. Which one? Anyone have an answer?
Adenoid cystic carcinoma.
Yeah, adenoid cystic carcinoma is characterized by pre-neural invasion. Of course, if we don't mention adenocystic carcinoma, so any parotid cancer can cause invasion of the facial nerve. Next question 49 is a 19 years old man was assaulted and sustained injury in the right side of his head. After 2 weeks, I think that, and to notice, I think this is wrong. He noticed that his right eye is dry and couldn't produce tear, from which ganglion is post-synaptic fiber arise to supply lacrimal gland. So you know that in the head and neck we have three common ganglia like otic ganglia, like sphenopalatine or pterygopalatine ganglia. You have submandibular ganglia. So which one lacrimal gland is relay? So lacrimal gland is relay in the sphenopalatine, or the other name is pterygopalatine ganglia. It's very common question. Next question is about 35 years old man undergoing right inguinal hernia repair, what we called it hernioplasty, under general anesthesia as a day case surgery. He has nerve block after the procedure. On recovery, he has weakness of the right leg, which is not usual in inguinal region nerve block. See, this something is not typical, because usually if they make a nerve block for the hernia, we anesthetize ilioinguinal and genital branch of genitofemoral. So it does not affect the movement of the leg at all. So this is by mistake. He have something happened. So which nerve cause weakness of the right leg? So anyone have an idea?
Ilioinguinal nerve.
No, ilioinguinal nerve will not affect the leg at all. This is why we say it is by mistake. So the answer here is femoral nerve. It is, of course, it is not a typical. This is why we repeated many times in the question, which nerve is affected by mistake, because ilioinguinal genital branch of genitofemoral is common to be anesthetized. But whatever happened, even if you cut it, is not paralyze the leg. But here it is femoral, so it is, I think, by mistake or something. Of course, usually the question of the anatomy, he need just to know the anatomy. He need to make it applied anatomy. Of course, this not happened in the real life. Next question, a man suffer from brachial plexus injury. On examination, they have Horner syndrome. Horner syndrome is very common because nowadays, for the treatment of the hyperhidrosis, we do what we call this cervical or thoracoscopic cervical sympathectomy. So we cut it the root below T1. But because it is become common for hyperhidrosis, is a common operation, so we can find Horner syndrome, which characterized by meiosis, anhidrosis, and inophthalmos. So nerve root does Horner syndrome suggested to be involved, so it must be including T1. So the answer here is C8T1. So it is a satellite ganglia. So it means that by mistake, or sometimes if the surgeon used the CERMI, This is advised now. Don't use the thermy to cut the sympathetic chain below T1 because sometimes the electrical current pass up and can cause Horner syndrome. So it's better to do two clips and cut between clips, or you can use harmonic scalpel, which is use ultrasound wave, not electrical wave. Next question, again, foramina of the skull is very important, very common, easy, and it is all or none. So it is either correct or not correct. 60 years old woman, breast carcinoma, complain of difficulty showing her food and found to have numbness in the lower lip on one side. CT scan show small metastatic lesion affect bony skull on the same side as the lip numbness. Which foramina is most involved? So I think he looking for mandibular nerve. So mandibular nerve affects the patient, so can affect the sensation and all this. So the question is, which foramina mandibular nerve pass through? Anyone have an answer? Foramen?
Ovale.
Foramen oval. Ovale. So foramen ovale is one of the foramina in which mandibular nerve is passed. Okay. Which one of the following muscle is extensor of the hip? What is the extensor of the hip?
Semitendinosus.
Semitendinosus. Okay. By the way, it is important to remember that iliopsoas muscle is inserted in lesser trochanter of the femur, and the iliacus muscle supplied by femoral nerve, and psoas muscle supplied by lumbar 1 and 2. So it is the same united muscle, but each part is by a separate nerve. Okay. The next one, for exposure of right axillary artery, transverse incision is made below the clavicle from point lateral to the sternal head of clavicle to deltopectoral groove. This is also very common. So which structure would we encounter in the section down to the vessels? Of course, the structure here is not important, the structure, but only in applied surgery, especially in trauma in this area, in stab wound, in the axillary clearance, or mastectomy can be injured. Which artery? Anyone?
Thoracoacromial artery.
Okay, thoracoacromial artery, although it is not important, arises from the second part of subclavian, or second part of axillary artery, sorry, but it is important in this section because it is tiny artery, have 4 branches, easy to bleed, but if elongated is not important, not give any important structure. Okay, next question is a 55 years old man presented to emergency department after collapsing. On examination, his pulse 124 beat per minute, blood pressure is 60/30 low, respiratory rate 34 high, and peripheral are warm. So this is important. Usually in most of the shock, the periphery is cold, except in this condition. What this condition? Anyone?
Sepsis.
Sepsis or septic shock is very important and they can cause that. Okay. In the posterolateral approach of posterior malleolar fracture, an incision is made between calcaneus, Achilles tendon, and distal fibula. Which the following structure is at risk? If you remember anatomy, we have important structure in this area. It is a nerve. Which nerve in this area? Give cutaneous blood nerve supply to the lateral part of the leg and little toe.
Sural nerve.
Yeah, sure nerve. Okay. Of course, the area of the big toe is supplied by partially by saphenous and superficial perineal, but laterally by sural nerve. Okay. Next question is a 25 years old woman undergo an elective right thoracoscopic procedure for treatment of right palmar aponeurosis. Diathermy is applied. Again, we mentioned diathermy is not good to put diathermy. It's better to use something like ultrasound wave or harmonic scalpel is applied to the neural structure lying anterior to the neck of the right rib. What most likely complication occur before these procedures? So in the operation of the thoracoscopic sympathectomy, something happened. Of course, we mentioned right side because in the left side we have another structure which is thoracic duct. Forget this. If you use the diathermy to cut T1 below, it is supposed to be below the stellate ganglia. So if the electrical wave pass up, it causes what?
Horner syndrome.
Horner syndrome. So again, nowadays we see a lot of Horner syndrome. Horner syndrome in past we don't see much. We just see it in the past due to something called apical tumor, apical lung tumor, what we call it pancreas tumor. But nowadays we see it much. What we called it is like thoracoscopic sympathectomy or something like that. Okay, so it is common to be seen nowadays. Next question is 33 years old man presented to the orthopedic outpatient clinic with a 6 months history of low backache radiating to the lateral aspect of the left upper thigh. So just here, remember the anatomy. So lateral aspect of the upper thigh, so it is most probably, it is L, for example, L2 or 3. Micturition defecation are normal, so S2, 3, 4 are intact. No history of previous injury on examination. Left lateral flexion of the spine is limited, but a full range of hip movement are observed. Although it is painful, the sensation altered over the front of the knee. Front of the knee sensation is L4. If you remember the dermatome of the thigh, L2, 3, 4. So above the knee is dermatome is L4. So this patient have L3, L4 is affected. Left knee reflex is reduced. Which spinal cord mostly lately compressed? Just remember, if you remember that, what is the knee reflex? What is the root value of knee reflex?
L4.
L4. And for the ankle reflex?
S1.
L5, S1 sometimes. Okay, so in this patient, they have L4 left knee reflex losses, have loss of sensation in this area in the lateral and the area of the in front of the knee. So which route you can suggest?
It's L3, L4.
Yeah, so this 3, 4. Why 3, 4? 4 for loss of knee reflex and L3 because he mentioned from the beginning is a pain radiated lateral aspect of the upper thigh, and also they have sensation is altered over the front of the knee. So it is from dermatome point of view L4 and 4, L3 and 4. So again, dermatome and dermatome, at least 10 question come in exam, especially upper limb, lower limb, can come again in the orthopedic in the paper too. 25 years old, the motorcyclist is admitted following RTA having sustained bilateral femoral fracture, rupture spleen, 6-day post-operative, 6-day post-operative. So it is important to remember it is 6-day because in the other version, you can find the same scenario 3-day. I tell you the difference now. Post-operatively, notice that confused, hypoxic, difficult to ventilate. Observation show blood pressure 120/80, regular pulse 88. Abarexia, so it is not pneumonia, no chest infection. Chest X-ray show bilateral diffused lung. Okay. Bilateral diffused lung infiltration. What is the most likely undergoing diagnosis?
ARDS.
Yes, ERDS. This is why we change it. This is 6. Because the chest X-ray to appear after ARDS, it need about 5 to 6 days. If no bilateral diffuse lung, so can be any chest infection or bronchopneumonia or others. Okay. So as I mentioned here, ARDS developed. It is developed early, but presentation as X-ray takes to 4 to 5. Of course, sometimes you can diagnose by ventilation, perfusion scan, and others. Okay. Next question is on the ultrasound scan on popliteal fossa. When investigated for a swelling, which following structure is close to the capsule of the knee joint. Close to the capsule means that it is deep structure. What is the deep structure in popliteal fossa? So it is anyone?
Popliteal artery.
Popliteal artery. So popliteal artery is the deepest structure in the popliteal fossa. Tibial nerve is a superficial structure, but if you speak from anatomy, like anterior structure is popliteal artery is considered anterior structure. All right. Next question, 61. 25 years old man sustained twisting injury while playing football. He developed immediate swelling in the neck, as we mentioned before in orthopedic. If the patient have immediate swelling, so it is cruciate ligament. If have late swelling, so it is what we called it, not collateral. What other ligament? It is meniscus. If it is no swelling at all, so it is collateral ligament. So immediate swelling, cruciate. Late swelling, meniscus. No swelling at all in the knee, so lateral or medial collateral ligament. So this immediate swelling, so now we are in cruciate. He can't contain the gym. 6 months later, he's still not able to play football. His knee feel unsteady, tend to give way. On examination, full range of movement is positive anterior withdrawal test. Okay, so we have two clues here. First, it is immediate, so can be anterior, can be posterior cruciate. But positive anterior withdrawal, so the answer now is anyone?
Anterior cruciate ligament.
Anterior cruciate, ACL. So it is easy. This question of the knee, because sometimes is look difficult, but again, just the rule. Immediate swelling, cruciate ligament. Late swelling, meniscus. No swelling, collateral ligament. And they give you some clue. It is anterior or posterior or medial and lateral according to details later. 62 years old man required partial gastrectomy and gastrogynostomy for large benign ulcer in his gastric antrum. Of course, nowadays, due to omeprazole and the proton pump inhibitor and treatment of H. pylori, we don't do that, but still have nowadays partial gastrectomy and gastrogynostomy for pediatric, not for gastric ulcer. When he received the clinic 6 months later, complained of palpitation, weakness, sweating, along with a cramp-like abdominal pain, which occur within 1 hour eating meal. Usually, he must lie down for half an hour or 30 to 40 minutes until symptoms subside. What most likely the cause of this symptom? This is what we call the dumping syndrome, because what happens, the patient eat a lot of the sugary material or food, because the food not stay much in the stomach, so they have high blood sugar, so hyperglycemia, insulin secreted in large amounts, so become hypoglycemia. So it is hyper, then hypoglycemia, what we call the dumping syndrome. So usually we advise the patient to take a small meal and don't take highly sugar or sugary fluid, just take normal food. So what we call the dumping syndrome. Okay. In septic shock, noradrenaline used to increase systematic vascular resistance. The action of norepinephrine is stimulated of the which receptor?
Alpha 1.
Alpha 1. So stimulation is by alpha 1. inhibition alpha 2. Dobutamine affect B1 is and B1 and B2. Okay. This question is very common and come again and usually with variation in number. 56 years old man presented with acute gastric pain and vomiting. On examination, he have guarding upper abdomen. First, you can see serum amylase is high, so it is acute pancreatitis. Now, we need to know what is the cause of acute pancreatitis. I just to go to the answer first, just to explain. Which of the following likely etiology? First, alcohol. So if the patient take alcohol, what happened to his liver? He become liver cirrhotic. So the liver enzymes, you can find the liver enzymes is become very high and the albumin is low. So have hypoalbuminemia, which is not here because the albumin is within normal and the liver enzyme is too much high. It is just 61, so it is not alcohol. Okay. After that, he mentioned it is or could be cholelithiasis, means a stone in the common bile duct. Okay. No, I just ask here. It is if it is obstructive jaundice, so bilirubin must be high. Bilirubin is normal, so it is not cholelithiasis. Okay. Hypertriglyceridemia occur if the triglyceride is very high and is not high. Hypocalcemia is not mentioned calcium level here. And usually pancreatitis can occur with hyper, not hypocalcemia. And pancreatitis can be result of it hypocalcemia, but hypercalcemia due to parathyroid can increase gastrin and can cause pancreatitis. Mumps, usually bilateral, and nowadays is very rare. It is virus infection. So by exclusion, again, I think we choose alcohol. So the answer will be alcohol because gamma GT is very high. Although the ALT is not so high, but because the gamma GT is high, so they have liver insult. So this is alcoholic liver, and this alcohol can also cause pancreatitis. Okay, it is tricky. In the same version, you can find the same question again. They put this normal, and they make the calcium is very high, and this is indicated hyperparathyroid or parathyroid is very high because if the parathyroid is high, increase the calcium. If calcium is high, increase gastrin, and sometimes can cause peptic ulcer and cause upper abdominal pain, and sometimes very rare can cause pancreatitis. So the answer here is alcohol because gamma GT is high. Okay. 47 years old woman with end-stage renal failure require elective cholecystectomy for symptom of gallbladder disease, gallstone disease. Hemoglobin preoperative is low, 7.2. It is indication of blood transfusion. What is the major cause of this anemia? Of course, in renal failure, what type of anemia we have? Anyone?
Erythropoietin deficiency.
Yes, but what type of anemia? It is normocytic normochromic because it is like hypoplasia of the bone marrow. Because the other type of anemia, like iron deficiency anemia, occurring bleeding, can be macroscopic hypochromic, but in the renal failure, it is normochromic, normocytic, and due to erythropoietin. This is why we give the patient every 1 month erythropex, which is erythropoietin injection every month. Okay, once a dose. Okay. 60 years old man undergoing cystectomy of the bladder carcinoma, so removal of the urinary bladder. During surgery, the ureter identify in which region the bladder of the bladder ureter bears the bladder wall. Anyone?
Posterior surface.
posterior surface, although I maybe have a picture here, although in some, if you look into it, it's 66, okay, just a minute. It is posterior, of course, correct. I just need to show you a picture. Okay. If you see the picture, so it is posterior, but it is look like lateral, but actually it's not lateral. Okay, and again, so the answer here is posterior surface, and again, no anterior surface because urinary bladder have no anterior surface. Urinary bladder have apex and the posterolateral or inferolateral and superior surface, and the ureter inserted in the posterior surface. Okay. So back again. 65 years old man had a colonic resection for carcinoma 12 hours ago. He is now passing concentrated urine at the rate of 0.0 ml per kilogram per hour, which is the minimal. Usually the normal is half ml to 1 ml per kilogram body weight per hour. This is not the question. The question, which endocrine response is most likely cause this? So what happened from endocrine point of view in any stress, any trauma, any surgery, which hormone is released? Okay. So the increase of vasopressin. Vasopressin, of course, it is antidiuretic hormone. Okay. 28-old man presented with ischorectal fossa abscess. Actually, ischorectal fossa or ischorectal abscess is the wrong name because if you see any picture, the ischorectal area is related to anus, is not related to the rectum. So the correct name in books nowadays is ischoanal, not ischorectal. But this is not a problem. Where is the abscess cavity like to be? So this is the abscess. First question, he write is above levator ani muscle. Levator ani is upper, so it is below, so wrong. Between external internal sphincter, external internal sphincter is medial to it, so it is wrong. If you have abscess between internal and external sphincter, it is just perianal abscess or fistula. Okay, so lateral to obturator internus is here, so it is not lateral, it is medial. Medial to internal internal sphincter here, so it is lateral. Medial ubidental canal, this is the pudendal canal, so medial to pudendal canal, this is correct answer. So you just need to imagine the ischorectal fossa, levator ani up, internal sphincter medial, obturator internus laterally. So it is medial to pudendal canal. Okay, so you just need some of imagination. Okay. 36 years old man full of his outstretched hand. Full of outstretched hand is very common cause of trauma and is a common cause of Colles fracture and fracture scaphoid. On examination, revealed tender in anatomical snuff box, so could be scaphoid bone fracture. So, but the question here is not. Question is which one of the following tendon is the boundaries of anatomical snuff box? Okay, of course, again, if you can you remember that we have in the middle border of the anatomical snuff box only one muscle, which is extensor pollicis longus. And laterally, we have two muscles, extensor pollicis brevis, abductor pollicis longus. Okay, so we have one muscle, two muscle. So he don't mention medial or lateral. So just one muscle is here. So we're looking for extensor pollicis longus. Extensor pollicis longus, here is the last one. If you're looking for abductor pollicis longus, is not written here, it is brevis. If you're looking for extensor pollicis brevis, not mentioned here. So extensor pollicis longus is correct. If we have abductor pollicis brevis, abductor pollicis longus, extensor pollicis brevis or abductor pollicis longus is correct. Boundaries of anatomical snap box is important, by the way. Okay, 55 years old woman complain of cramp, tingling in her leg and the arm 48 hours following total thyroidectomy or subtotal thyroidectomy. Of course, after thyroid surgery, you know that we can cut or impair the blood supply to important gland, which is parathyroid gland. So the patient can have hypokalemia and can have some problem. So we can see the scenario. Fetal sign is stable. Investigation reveal normal white blood cell count, normal hemoglobin, sodium was normal, potassium normal, calcium very low, serum albumin is normal. So appropriate intravenous infusion for this patient. Okay, so we need to give her calcium. So they usually, in most of the country, will give calcium glyconate. In some countries, they give calcium chloride. Usually, it is 10%, 10 milli within 10 minutes. Calcium glyconate or calcium chloride. A 40 years old woman presented with fecal incontinence, anatomical intact internal external sphincter, which structure most likely to have been damaged. This is repeated again and again. Which nerve? Anyone can answer?
Pudendal nerve.
Pudendal nerve. Okay. Next question. Have a tricky. Also have a lot of debate in some version. Abdominal free fluid collect in the lower part of the peritoneal cavity at operation with patient supine. Which of the following site is the following collected? So if you see this picture, of course, my opinion is according the operation. If the appendicectomy, so can be in the lower part. If the upper operation can be hepatorenal pouch. But actually, from the anatomical point of view, they found the lower part of peritoneal cavity is hepatorenal pouch, and usually the patient in a spine position post-operative. So whatever the collection, it is the hepatorenal is more lower than paracolic pouches or paracolic gutter. So usually the answer is hepatorenal pouch. Okay. Even if the patient have something like appendicectomy, also hepatorenal pouch is the first collection. After that can be in the paracolic gutter. Of course, right paracolic gutter. Next question, 45 years old, homeless man presented with cough and weight loss. Usually, if you mention in England homeless man or something, or overseas, or patient came from other country like India, so most probably he looking for TB. Or some like immunocompromised patient and all this. On examination, BMI 19, low, reduced breath sound in the right upper zone. Of course, as you remember, in TB is usually in the apical lesion. Chest X-ray show cavity in the right upper lobe. Undergoing bronchoscope, bronchial biopsy. Biopsy show feature necrosis surrounded by macrophage or epithelioid cell and giant cell. Of course, epithelioid cell is the same term of giant cell, is the same term of multinucleated cell. So what is most likely diagnosis? Of course, actinomycosis can occur in lung, but not cause apical lesion, very rare. Bronchiectasis is bilateral. Sarcoidosis make hilar lymph node. Squamous cell carcinoma usually occur in the center area and the chronic smoker. So this is TB characterized by granuloma, which is epithelioid cell with central necrosis or central caseation. Okay. A healthy 36 years old man is being assessed to be life-related kidney donor. Which are the following investigation most accurate to measure the glomerular filtration rate? Anyone know the answer?
Inulin clearance.
Yes, so is this correct? But what is para-aminobutyric acid used for?
Renal plasma flow.
Yes, renal plasma flow. So again, it is important to answer because in exam, it is important. In exam, we use the same question, but we can make it instead. What is the most accurate for measuring renal plasma flow? So answer become para-aminobutyric acid. So this is important. The college found the easy way to put student down. We use the same question and just change the key question, like which of which is that. Sometimes what increase, what decrease, all this. So it is very important to recognize that. 34 years old pregnant woman, so she is young. Swelling leg can be deep venous thrombosis. Her mother, maternal aunt, also similar problem during their pregnancy. So the whole family have something related to thrombosis, especially at time of pregnancy. All the family have deep venous thrombosis, so something run in family. So, of course, in this question, it is important to know what is everything, like anti-endomythelial antibodies. It is in which disease? Increase in which
Celiac
disease?
disease.
Celiac disease, which is rare, it is called gluten enteropathy. Anti-mitochondrial antibody, in which disease? Primary biliary cirrhosis. Anti-nuclear antibodies, common, which disease? Systemic lupus.
SLE.
Yes, SLE. Anti-thyroglobulin antibodies in Hashimoto and thyroiditis. So anti-phospholipid antibodies or anti-cardiobin antibodies is the cause of the deep venous thrombosis can run in family. Of course, we don't ask about the other, but just to need what is the other mean. Next question is 62 years old alcoholic man, also chronic smoker, well known suffer from chronic obstructive airway disease or chronic obstructive pulmonary disease. He now diagnosed as carcinoma of urinary bladder and the history of gastric ulcer. So which of the following agent likely responsible for all these problems? So this patient have something in the lung, but have urinary bladder cancer. So which one of these can cause bladder cancer?
Cigarette smoking.
Yeah, cigarette smoking, cancer urinary bladder can occur in smoker, can occur in people who work in aluminum dye or some dye industry. 3-year-old boy admitted to hospital with severe vomiting. Radiographic examination and history revealed that suffering from annular pancreas. Annular pancreas is one of congenital anomaly. It's embryology. So which of this structure is constricted? So it is which part of duodenum? From anatomy, of course, you know 1, 2, 3, 4 part of duodenum. So if you have annular pancreas, so must be related to which part of duodenum? Anyone?
Second part of the duodenum.
Second part of duodenum. Okay. 45 years old man presented with 3 times 4 cm bell swelling in right groin. Cough and pulse is positive. So cough and pulse is positive, so it is with hernia. At operation, indirect inguinal hernia is found. External inguinal ring is a... So this is question he just asked in anatomy. The external inguinal ring is defective of which muscle? So from the anatomy, we have external, internal, and transversus muscle. Transversus can be fascia transversalis, internal can be cremasteric muscle, external can be external spermatic fascia, but the external inguinal ring is defective in which muscle? Anyone? If you open the skin, subcutaneous and
External oblique.
external oblique aponeurosis. So it is defect in the external oblique aponeurosis, which is continuation of external oblique muscle. Of course, this is anatomy question. By the way, in exam, as we mentioned before, 300 question. We have 75 question in anatomy, so big bulk in anatomy. And again, most of the orthopedic question is related to anatomy, like fracture of this area related to which nerve and all these, dermatome, myotome. So anatomy is the key of this exam. Okay, 69. 45 years old woman suffer from spina bifida, confined to wheelchair. Her leg is not fully developed. Okay, so this have a spina bifida, maybe meningomyelocele because it can have paralysis. So the pathology is okay. What we call this pathology?
Hypoplasia.
Okay, so it is a case of hypoplasia. But if the patient is well developed and suddenly have polio or something, we call it atrophy. But because it is congenital, so it is hypoplasia. Next question. 23-old man presented to emergency department with non-specific chest pain. Posterior chest radiology, which is normal position, is performed and it is normal. Immediately inferior caudal to the outline of aortic knuckle. What is structure? What is the convex border is the structure. Usually they give a picture. I think they have a picture here. In exam, of course, you have a picture because the exam now on computer. This is aortic knuckle, and they put an arrow and ask, what is this? So anyone?
Pulmonary trunk.
Pulmonary trunk. Of course, you can find aortic knuckle, pulmonary trunk, left atrium, left ventricle, the border of the heart. This is very important. Of course, X-ray come to an exam is normal anatomy because this is anatomy question. Maybe in the paper too can have widening mediastinum for aortic, thoracic aortic aneurysm and all this. Okay, a 45 old woman presented with the hospital with jaundice. She's diagnosed by ultrasound and confirmed CT hepatocellular carcinoma, affect the left lobe of the liver. Which virus is most likely to cause? Which virus can cause hepatocellular carcinoma? Anyone?
Hepatitis B.
Hepatitis B. Of course, hepatitis B, hepatitis C can, hepatitis A not cause. What is the tumor marker for hepatocellular carcinoma?
Alpha fetoprotein.
Alpha fetoprotein, good. All right. Next question. 82-old man has complete occlusion of inferior mesenteric artery on angio, but no symptom of sign of colonic ischemia. This is common nowadays. Why it is common nowadays? Because nowadays for abdominal aortic aneurysm, we don't do surgery. What we do, we put something called the EVAR. EVAR is the insertion of the stent, and this is a stent have no opening for inferior mesenteric. So what happened? This occludes the inferior mesenteric. If the inferior mesenteric occluded, theoretically, this patient most probably have ischemia of the colon, but we don't found the patient have ischemia of the colon. He have some pain like ischemic colitis, but have no ischemia. It is due to what? Anyone?
Left colic artery.
Say again.
Left colic artery.
You mean it is not left colic, it is the left branch of middle colic. If you remember the anatomy, we have right colic and middle colic from superior mesenteric. The middle colic have right branch and the left branch. So it is middle colic. So the answer is middle colic. Okay? Because the others, left colic is from inferior mesenteric is already occluded. So the answer here is middle colic. Okay? It's very common. I think in the answer sheet, I put a picture for that. Okay, next question, 83, 56 years old man, chronic smoker, alcoholic, insulin-dependent diabetes mellitus, presented to surgical outpatient clinic with 3 months history of right leg pain, brought on by walking 50 meters. So it is very late stage because it is like small amount or small period of walking, so intermediate qualification is less. He has no history of backache. In clinical examination, significant found include weak right foot pulse, so the pulsation in the right foot dorsalis pedis is weak. Sensation in dorsum of the foot is also impaired or altered. So what is most likely diagnosis? Just easy. What is the common site of ischemia? Anyone? Common site of lower limb obstruction or ischemia or narrowing is
Superficial femoral artery.
superficial femoral artery. So it is the end of femoral to become popliteal. So we can call it femoral popliteal stenosis. So this is a common site of ischemia due to atherosclerosis. Is different from bilateral ischemia due to thromboangiitis obliteranis or Berger disease, which is in chronic smoker and affect most of the middle-sized arteries. But the common in atherosclerosis old people is femoral-popliteal or superficial femoral artery end. Okay, 35. Old man presented with 3-week history of low backache and 3-day history of pain and weakness in the left leg. Physical examination demonstrates numbness over the posterior aspect of the left cuff extended to the lateral aspect of the foot. Left ankle reflex is absent. MRI show compression of the left S1 nerve root, which is most likely structure compressed of this nerve. Although he big scenario, and I suppose he asked you about some of the anatomy, but he need to ask you about anatomy of the disc. We know that the disc is 2-part, nucleus pulposa and annulus fibrosa. He need to ask which one of these compresses the nerve, is the annular fibrosa or nucleus pulposa. So anyone has the answer?
Nucleus pulposus.
Nucleus pulposus. So usually the central posterior part, so nucleus pulposus. Next question, 72, old man, chronic smoker, presented to his doctor with a second episode of painless frank hematuria. Usually hematuria, if painless, can be cancer. Can be urinary bladder cancer, can be renal cell carcinoma. Of course, a chronic smoker can have both renal cell carcinoma and transition cell carcinoma. With ultrasound scan, urinary tract performed, it is solid lesion in the right kidney. Okay, so now it is a kidney. So what is likely diagnosis? We can start the first one. Angiomyolipoma, it is like hemangioma in the kidney. It is benign lesion. Renal cyst is a benign lesion. Renal oncocytoma, I think nothing called that. I don't know this. So we have 2 tumors, renal and transitional cell carcinoma, usually in the bladder. So this is in the right kidney, painless frank hematuria. So the answer is renal cell carcinoma. Renal cell carcinoma characterized by 3 triads, which is swelling, renal swelling, painless frank hematuria, and polycythemia. Polycythemia means increased number of RBCs. Anyone know why patient with renal cell carcinoma have polycythemia? Why this patient of renal cell carcinoma have polycythemia?
Paraneoplastic syndrome.
Yeah, paraneoplastic due to increase of erythropoietin. Okay. So it is important to know that. Of course, erythropoietin now is secreted from pretubular cell. In all the book is just a glomerulus apparatus. Now it is from pretubular cell. Okay, next question. So the answer here is renal cell carcinoma. Next question, 86, 20 years old man from Southeast Asia, presented with abdominal pain and shock. He found have hemoproteinemia due to rupture spleen. Although it is not common nowadays, but what is written in the book, they believe that in the Southeast Asia, which is including Malaysia, Thailand, and all these countries, the patient can have rupture of the spleen, which is not common nowadays. It is historical. No history of trauma, which most likely predisposing factor. Of course, in the past, Southeast Asia is famous by malaria, and the malaria or dengue now can cause huge spleen. But also they have another disease. What is other disease can cause increase in spleen in Southeast Asia or all over the world? Anyone? Apart from
Epstein-Barr
malaria,
virus.
apart from dengue, say again. Epstein-Barr virus. What is the
Epstein-Barr
name of
virus.
disease? What is the name of disease?
Infectious mononucleosis.
Infection mononucleosis. So infection mononucleosis can cause enlarged spleen. I don't see can be cause rupture, but they still some believe that rupture of spleen occur in Asian due to huge spleen, either due to malaria or due to infection mononucleosis. Okay. After that, we have a 30 years old woman presented in outpatient clinic with 3 months history of diarrhea, which is intermittent bloody, so bloody diarrhea. Again, it is important to know, if we mention woman, we don't know nationality, so it is considered British. So this question is 30 years old, British woman. On rectal biopsy, histology show granuloma inflammation. What most likely? So this British lady have bloody diarrhea, have granuloma. What's your diagnosis? Anyone?
Crohn's disease.
Crohn's disease. Of course, it is not TB. TB don't cause bloody diarrhea. TB also can affect the intestine, can cause colonic ulcer or something. But again, if any question, we don't mention nationality. It is a British exam, so it is a British woman. Very important to notice that. Next question. 56 years old, motorcycle, chronic smoker, hypertension, presented to emergency department of being involved in RTA, conscious, Glasgow scale is 13/15, patent airway breathing, so AB is okay, found has compound open right femoral fracture. Compound mean open. Compound open is the same word. Communicated is mean multiple pieces, but this is compound, mean open. Of course, in any open fracture or any compound fracture, it's better to do external fixation. Okay. Compound open right femoral fracture with normal distal pulsation and sensation. So it is important to know that sensation is important, so you don't need to consult the vascular surgeon because vascularity is very, very, very important in any leg injury. Resuscitation start, urethral catheter drain 200 ml immediately, but over the period of 60 minutes, so 1 hour, he drain only 10 milli. What the following is most likely cause of oliguria? So this patient have oliguria. Here we don't mention the blood pressure. Of course, difficult to have block the catheter because already have some amount. So not block the catheter. If I say nothing and the patient is stable, blood pressure is okay, so can be block the catheter. No mention about any cardiac condition. So what it could be?
Hypovolemic shock.
Hypovolemic shock. Of course, yes, correct. If rupture bladder, urinary bladder, the patient unable to pass urine, and by fast scan, you can find free fluid in the pelvis. This is one of the important to do fast scan. So hypovolemic shock. Okay. Next question. Sometimes I have a debate also for this question. Is a 35 years old man admitted with acute pancreatitis, which lead to admission to surgical high dependency unit HDU. After 48 hours, he developed breathing difficulty. 48 hours. Increased respiratory rate, hypoxia. You suspect he developed respiratory failure. Which of the following mechanism responsible for regulation of respiration? So he asked about in the patient in trauma, what is the stimulation of respiration? It is high oxygen or CO2 in medulla. Anyone have an idea?
CO2 in medulla.
Yeah, C2, yes. So the simulation here is CO2 concentration in medulla. So it is wise don't give the patient high dose of oxygen or 100% oxygen because one of simulation is the level of CO2 carbon dioxide. Next question. He speak about something, of course, it is anatomy question. 70 years old man undergo transurethral resection of bladder tumor. The tumor lie over the lateral wall of the bladder, just above the opening of right ureteric orifice. The use of the therapy suddenly caused patient to kick because of the contraction of adductor muscle. Of course, theoretically it's not happened, but because the anatomy people usually he need to put the anatomical knowledge in what we called it in something like case presentation. So he just need to ask you which nerve give blood nerve supply to adductor muscle. What is your answer? Which nerve give
Obturator nerve.
adductor of the thigh? Obturator nerve. Good. Next question. Which of the following statement is true in relation to cardiac muscle? Again, this type of question is not appear in exam, but I think we see it many times. So contraction don't involve the release of calcium. Contraction need calcium influx, so A is wrong. Contraction is triggered by influx of the calcium, so it's correct through the sacrolemma. So the answer is B. Of course, the other hypertrophy or all this is not correct. 39 years old man presented with tearing left side loin to groin pain. Loin to groin, so it is ureteric colic. So renal stone or ureteric stone. Investigation radio opaque. Radio opaque stone, so can be anything except uric acid because uric and urate is not appear in the X-ray. Which most likely composition of the ureteric stone. So if you see this option, you can find cysteine occur in baby, in young, not in 39 because it is metabolic disorder. Urate not appear in X-ray. Cholesterol is in gallbladder, not in urinary system. So we only have A and B can be correct. Okay. So ammonium magnesium phosphate is a staghorn stone and usually appear in the pelvis of the kidney. Okay, but here it is in the ureter. So what is your answer?
calcium oxalate.
Yes. Again, if this question come to exam, can be radio opaque tense obesity is seen in the pelvic junction in the IVB or IVU. So the answer become ammonium magnesium phosphate. So it is important. Again, I repeat it many times. This question is the same common exam, just a little change in something in this. Make, for example, in one version B is correct, in other version A correct, in other version C is correct. So it is very important. This is why this Fawzia sheet is popular all over the world. If you Google, I just what is called, I put you a link of another YouTube channel. The answer is the same sheet, just for comparison. You can use it. You can find it in chat box now. Just if you go to chat box, you can copy and put in your computer. Next question, 93. A 25 years old man is playing football when he complained of posterior thigh pain while sprinting with the ball. On examination, he has tender in the lower lateral posterior thigh. Lower lateral posterior thigh, so it is the area of popliteal fossa. He unable to fully extend the knee due to pain. So what is most likely injury? So which muscle in the lower lateral part of the thigh or lateral border of popliteal fossa? Anyone?
Bicep femoris.
Yeah, biceps femoris tendon tear. Okay. 23 old man is assaulted and sustained stab injury left groin. The wound is clean and simple dressing is applied. 6 months later, the patient returned with a pulsatile swelling at the site of injury. Most probable lesion present is. So after bile trauma, after femoral artery cannulation for dialysis or for sampling. Patient after few months develop pulsatile swelling. So what is this swelling could be?
Pseudoaneurysm.
Pseudoaneurysm, false aneurysm or pseudoaneurysm of femoral artery. This is due to that when you insert the cannula or the needle, you dissect the artery, so it is passed between the intima and the media, so make a dissecting something like atherogenic or pseudoaneurysm because it is not include the whole layer of the artery. It is common nowadays because the femoral, the cardiac sterilization and all this. 12 years old girl has diastolic murmur, maximum audible second left intercostal space. Second left. Pathology of which structure is most likely. So it is like anatomy question. But we don't interested about murmur in surgery, but this is anatomy question. Thorax is very important topic in the exam, like head and neck. So second left intercostal space, which valve in this area?
Pulmonary
Pulmonary artery. Okay. So just this anatomical question. Okay. Next question is 25 years old man is admitted have been stabbed in the inferior chest. On examination is alert, coherent, he congested neck vein. So first congested neck vein. Pulse high 140, blood pressure is low, so the patient have congested neck vein, low blood pressure, has normal breathing sound. We mentioned normal breathing sound. Why? To exclude tension pneumothorax. So what is most likely cause of this cardiac arrest 15 minutes later? So what is this patient have?
Cardiac tamponade.
Cardiac tamponade. Cardiac tamponade cause something what we called it Bextriad. Bextriad is weak heart sound or muffled heart sound, hypotension, and congested neck vein. Usually we do urgent precardiocentesis guided by echo or ultrasound and ECG. Okay, so precardiocentesis is urgent. Of course, we diagnose now cardiac tamponade by what we call the fast scan, which is focal assessment sonography for trauma. Next question. Okay, 20 years old woman presented with acutely abdominal pain, imaging reveal right ovarian cyst lesion. So 20 have ovarian cyst. Exercise histological examination shows cyst lying by keratinized cervical squamous epithelium, fat, muscle, thyroid, neural crest, neural tissue. So this is what we call the totipotent or multiple cyst like endoderm, mesoderm, ectoderm cell in the same lesion and usually in young. So something like not congenital but like embryological anomalies or something like that. So what we call this tumor?
Teratoma.
Teratoma. Okay. 21 years old man is come to emergency department with severe headache, neck stiffness, and recent onset. You suspect acute meningitis and decide immediately to treat with antibiotic and perform lumbar puncture. After your third attempt to obtain CSF, he noticed that the fluid obtains stained red. However, during the collection of CS into the 3 container, is noticed the final bottle is now clear for any blood. He just need what is the anatomical structure responsible for bleeding. Of course, you remember if you go to the lumbar puncture, you have skin, subcutaneous tissue, supraspinatus, intraspinatus ligament, ligamentum flava, epidural space, and the epidural space contain plexus with the name of vein in the epidural space. Anyone?
Vertebral venous plexus.
Yeah, it is vertebral venous plexus. Actually, we don't have something called subarachnoid vein, maybe, but I don't know. But it is vertebral venous plexus. So again, in the lumbar puncture, we start by skin, subcutaneous, supra, intraspinous ligament, ligamentum flavum, and after that epidural space and vertebral venous plexus. So it is important to know that. Okay. All right. After that, this is very important question. Sometimes some students found difficult. I add some of it. I show you what I added. It's 25 years old woman, so she's young. Presented to surgical clinic with 3 months history of diarrhea. On examination, they found have smooth 2 cm swelling in front of her neck. Her sister have a similar swelling, which is operated 2 years ago, and the swelling move up with swallowing, so it is a thyroid. On the patient is clinically euthyroid, 5 needle aspirated cytology show amyloidostroma, and serum calcitonin is elevated. So this patient have thyroid swelling, have high serum calcitonin. So it is which type of, and it is run in family. So they have, of course, goiter run in family due to lack of iodine, but only one cancer run in family, which is medullary thyroid carcinoma. Medullary thyroid carcinoma can run in family if it is part of multiple endocrine neoplasm type 2, which is associating with pheochromocytoma. And it is characterized by amyloidostroma, and the tumor marker for medullary thyroid carcinoma is serum calcitonin. It is the only tumor marker for the thyroid tumors. Medullary thyroid carcinoma, multiple endocrine neoplasm is very important topic in the exam. Next question, 100. 74 years old man, well known as benign prostatic hyperplasia, presented to emergency department with acute urinary obstruction or retention. 30 minutes after urinary catheterization, he collapsed. Blood pressure low, heart rate high, most likely diagnosis. This is occur sometimes if the patient go to put a catheter and collapsed and the penis edema of the penis and the patient look like shock. What is the cause of this?
Sorry. Latex
Latex.
allergy. Latex
It
allergy.
is which type of hypersensitivity reaction?
Type
Type 1 or 2? Type 1. So it is type 1. So it is like type 1 anaphylactic type of reaction. It is can occur if the first time to wear gloves, if the first time to have a put a catheter. But suppose this patient, he wear a glove for many years and suddenly they have this allergy, or he put a catheter. It's difficult to put a catheter for many years, but suppose you have a gloves for many years, you work in surgery in 20 years, suddenly you have this reaction. Which type of sensitivity can be?
Type 4.
Type 4. So it is delay hypersensitivity reaction. So it is important to know it is first time or late. Okay. 70 years old man with basal cell carcinoma resected from the left temple, which is the most appropriate prognostic indicator. Of course, basal cell carcinoma is locally malignant, not spread, never spread, not go to lymphatic, not like melanoma, not like squamous cell carcinoma. So to excise with good safety margin is a big achievement. So if you make complete excision with safety margin minimal half centimeter, it is good. We don't need to looking for lymph node. We don't need to looking for anything. So the answer here is a completion of excision. Of course, invasion of the thickness or Clark level or Breslow thickness, it is in melanomas, not in basal cell carcinoma. 102, 68 years old man has undergone emergency surgery to repair leaking abdominal aortic aneurysm. He underwent transfusion 6 units of bagged RBCs. Usually, if the patient have a lot of blood transfusion, put in your mind either have DIC, disseminated intravascular coagulopathy, or something in the lung like ARDS. So blood tests were performed 2 hours post-operative. Hemoglobin is 10, little low. White blood cell is okay. Platelets very low. ABTT with a normal. INR high. Fibrinogen 0.5. FDB, fibrin degradation product, is 25, which is very, very high milliliter, because the normal, usually in exam, we put you the normal value. Okay, so this patient have high VDP. If you find high VDP, so what you choose from this DIC, all this, what you choose? Anyone?
DIC.
DIC. Of course, if we mention something like thrombosis, and this is like, for example, this patient is young and have a stroke or something, can put protein S, protein C, and the phospholipids can be the cause. Okay, 103 is a 46 years old woman, is seen in pre-admission clinic. She has MI 2 years ago. On examination, she is in AF. Of course, AF is very serious because can cause shower emboli. A recent echo shows he had dilated left ventricle. She is on warfarin, and her INR, which is international normalizing ratio, is 6.1, so it is very, very, very high. It is compatible with life, but is okay. Warfarin, the question here, warfarin inhibit which of the following? So he just need to ask warfarin act on. What is your answer?
Prothrombin.
Berothrombin. Okay. 29 years old pregnant woman have uncontrolled labor pain. She has an epidural for pain relief. What the following is true? This is difficult, so we take it one by one. An epidural punction should only be performed below L1 level to avoid damage of spinal cord. It is not only, it can be between L1, L2, can be lower, so it is not only. Epidural punction should only be performed below L4 or between L3 and 4 to avoid spinal cord. So epidural can be below or between L3, 4 is the correct answer. Epidural space or extradural space contain numerous nerve root and venous plexus. Contain numerous nerve root is correct, but venous plexus is not correct. Ligamentum flava is really burst. No, ligamentum flava must be burst. Supraspinatus, interspinatus really not must be burst. So again, we go through the skin, supraspinous, interspinous, ligamentum flavum, and go to the space. So this is the epidural space, and the ideal is between L3 and 4. Again, epidural is very, very, very important. Because you must have something in anesthesia, and epidural is the common used for anesthesia. Okay. Next question, I think is look repeated. A 28 years old motorcycle presented to emergency department after being involved in RTA. He has closed isolated injury of the right leg. Okay. All right. Okay, just a minute. Okay, he is closed isolated injury right leg. Radiograph show segment fracture of tibia and fibula. Intramedullary nailing of tibia is undertaken. 6 hours following the operation, he complained of severe calf pain and do not respond to analgesic. Movement of the toe severely increase the pain. What most likely the cause? Okay, so of course this is impossible to be deep venous thrombosis because it needs to take a time. And this is just 6 hours after open surgery. because intramedullary they have a lot of work, so they put a nail inside the tibia, for example. So what happened? Of course, not DVT, not infection, because it is infection not appear after 6 hours. Not thromboembolic episode also. So what is the answer?
D. Place intra-compartment pressure.
Okay, so how to manage this condition?
Fasciotomy.
It can be fasciotomy, but because this patient is due to surgery, so most probably have a bleeding point. So it is important in this condition to re-expose the wound, reopen the wound. But it's suppose it is just compartment syndrome without surgery, so you can make fasciotomy. But here it's better to explore the wound, maybe injury, what we call it iatrogenic injury during the surgery. Next question, 65 years old woman with a metastatic cancer breast, admitted to hospital confused and acutely unwell. It is important to know one of the common complications of metastasis of the breast, especially in bone. They have osteolytic secondaries. They increase the level of calcium, and in this condition, the patient have confusion. Vital sign was normal, abnormality most likely. So this is case of anyone?
Hypercalcemia.
Hypercalcemia. How to treat it?
And ibizometa.
No. What is the first line of treatment? This is the second.
Hydration.
Hydration. So it is important if the patient have hypercalcemia, just give a plenty of fluid or intravenous fluid. Okay, very, very important. Both after that calcium chelator. Biphosphonate, diphosphonate, we have a lot. Okay. 35-old obese woman during recovery from varicose vein surgery complain of weakness or dorsiflexion of the ankle. Okay, dorsiflexion of the ankle. Physical examination reveal absent sensation over the dorsum of the foot. Which of the following nerve is most likely compressed due to position in the operation? Okay. Anyone have an idea?
Common peroneal nerve.
Common peroneal nerve. Okay. I try to show you maybe in these conditions we have 107. Okay. Position of the patient, maybe. Okay, yes, I just share with you the picture. You can see this patient on table. Okay, you see the picture?
Yes, Prof.
Yes, so we can find 3 points of comparison. The common is common perineum here, lateral femoral cutaneous nerve of the thigh, saphenous nerve sometimes, but usually common perineum. And they can, in some patients, can cause foot drop. This is due to compression from the metal part in the operative theater metal, especially if the patient is just inserted or compressed in this area. So it is very important to notice that. Okay, it can happen. I see it once in my life, but can happen, by the way. And it is curable because this is just neuropyrexia, so this is improved. Okay, 808. Next question. 78 years old woman with chronic obstructive airway. Once you found obstructive airway, so put in your mind respiratory something, acidosis and all this. Become confused after right hemicolectomy, 70 oxygen, hair blood, gases, PO2 low, BCO2 high. So what is most likely? What does this patient have? It is which type of failure?
Type 2 respiratory failure.
Type 2. Okay. I just looking for if this patient, he don't mention the day, but if the patient mentions something like 10 days after operation and she is bedridden, can put in mind pulmonary embolism, but this is respiratory failure because in the respiratory failure type 2, there is hypoxia with increased CO2. In type 1, the hypoxia without increased BCO2. All right. So pulmonary embolus correct if 10 days after surgery. Okay. Next question. 19-old man fell down a flight of stairs, is presented in emergency department, Glasgow scale 14/15, so it is good. No focal neurological sign. An hour later, he vomit. Glasgow scale deteriorated to 10. He developed fixed dilated pupil. What's the following account for pupillary sign? Pupillary sign. So he just need to know if the patient have fixed dilated pupil due to compression of which nerve? Which nerve can affect this?
Optic chiasma.
Not optic chiasma. It is like oculomotor, and oculomotor nerve by parasympathetic fiber. So this is compression of oculomotor nerve. Optic chiasma can cause by temporal hemanopia, don't cause fixed dilated pupil. So the fixed dilated pupil usually due to affection of oculomotor. Okay. 32 years old mountain bike presented to outpatient clinic. He fell awkwardly. He excessive lateral flexion of his neck to the left side. He described some paresthesia over the right shoulder and the lateral arm, which appear to be improved over past hour. What most likely injuries suggests for this? So, of course, this is something improve. So if something improve, so it is not emesis, not actinotemesis, not neurotemesis, not cutting of the nerve. It is just a compression of the nerve, what we call it neuropyrexia. So can be C or D. So it is neuropyrexia. But he mentioned it is the right shoulder of the lateral arm, which sometimes in some books, this area we called it batch sign, like when you put batches here. So usually it is supplied by cervical 4 and 5. So in this patient, the answer is neuropyrexia C5. C5 from dermatome, neuropyrexia because the patient improved. But if say this patient never improved, so can be neurotemesis C2 can be correct. Okay. 62 years old woman presented with firm irregular mass in upper outer quadrant of the right breast. So of course upper outer quadrant is usually with a cancer. This appear malignant on mammogram. Fine needle aspirated cytology report is C5, which mean malignant. The question is different. He asked about what is the first lymph node metastasize. The first lymph node, we called it guard lymph node. Guard in Latin or English, we called it sentinel lymph node. Usually we know sentinel lymph node either by put methylene blue or dye in the breast and see the first lymph node have this dye, which is all the methods. Nowadays we inject radioactive material and use some probe, special indicator probe, so they can tell you which lymph node is first involved. Okay. Next question is 50 years old woman, multipara, presented with a history of fecal incontinence over the past few years. She has prolonged difficult first stage of labor 20 years previously. Physical examination relief lax anal sphincter. Of course, nowadays we have endo-anal manometric studies, so we can diagnose all this. But he this anatomy question. He asked about branches which nerve is likely being damaged to the labor. So the answer, of course, it is pudendal nerve S2, 3, and 4. Next question, important also because a 26 years old man presented in emergency department with extensive bleeding from his arm after sustained a glass injury. On examination. There is 6 cm transverse laceration across the anterior aspect of the elbow. On exploration, cubital fossa, you would expected brachial artery position. Okay, so brachial artery position. First, anterior to median nerve. Of course, you know, median nerve have triple relation to brachial artery. First, above is lateral, front, and in cubital fossa become medial. So it is wrong. Lateral to biceps tendon. It is not lateral. The biceps tendon is lateral to it. Lateral to median nerve is correct because median nerve in this position become medial to it, so the artery is lateral. So it is correct. So the answer is lateral to median nerve. I just try to show you the picture because it is very important question. Attention. No, I have no picture here, I think. Okay. I maybe saw you later. Okay. Okay, we go to the next question. The next question is about 53 years old man, chronic smoker, complain of chest pain. He has a history of hypertension, pulse is high, 138, blood pressure 140 over 90 millimeter mercury. What's the principal cause of underlying reduced coronary blood flow? It is important to know that coronary blood flow is mainly at diastole. So any factor can increase the heart rate or decrease the diastolic time can be dangerous for the coronary. So this is why the answer here, anyone knows the answer?
Decrease diastolic interval.
Yes, a decrease diastolic interval. So any factor affected the diastole can be the cause. All right. 58, very important question also. Woman, a known patient with thoracic right-sided meningioma. Usually we put meningioma because in the classic books they say mention incomplete injury of spinal cord. Actually, incomplete injury of spinal cord is historical because if the patient have incomplete injury of spinal cord during transportation by ambulance, incomplete become complete. But to mention something mimic that the patient have incomplete injury, so we mentioned that this patient have meningioma, which is benign tumor. By compression of the spinal cord, he makes something like pressure necrosis. So the patient can be presented with partial spinal cord injury, what we call it Brown-Sequard syndrome. Of course, in Brown-Sequard syndrome, he's in right side. So the classic way or easy way, he affects the right side weakness and sensation in the left side. So can anyone choose which one here we can be the correct answer?
Boy. Right-sided weakness. Loss
Yeah,
of
B.
perception and vibration. Yeah.
Okay, so it is B. Right-sided weakness, loss proprioception, vibration, left side, or loss of pen break. In final revisions, we have some collection of this incomplete spinal cord injury. Okay. 70 years old woman presented with fracture left femur, X-ratio osteolytic lesion. Of course, again, if you have osteolytic lesion, it is with secondaries, and whatever the cancer, histological examination of sample taken at time of internal fixation show metastatic carcinoma. Of course, we know that all cancer is osteolytic except one cancer, which is cancer prostate, is osteogenic. Here he mentioned breast, mentioned colon, mentioned endometrium, ovary, stomach. So which one of these tumor can cause bone secondaries? Anyone?
Breast.
Breast. Okay. Because breast is common in female, breast is common to have bone secondaries. Colon can give liver secondaries, endometrium lymph node, ovary can be lymph node, stomach lymph node, but not go to the bone. So usually characterized bone secondaries is breast. 74 years old man presented pulsatile epigastric swelling in his abdomen. Of course, it is abdominal aortic aneurysm. He needs to ask about the principal abnormality within the wall of the artery. Of course, this is dilatation due to weakness of the muscle. And this muscle contain either collagen or elastin. This muscle in media. So can be collagen, can be elastin. So which one can cause dilatation of the any artery? Is the elastin or collagen? Anyone?
Media elastin.
Elastin. The elastin is can cause, although in the anomalies or autosomal disease like Marfan syndrome due to collagen is also can be cause thoracic aortic aneurysm, but in the traditional abdominal aortic aneurysm, it is occur in muscle, so it is media, and the subsequent responses is elastin, not collagen. 24 years old woman presented with swelling in the thyroid gland. She is also enlarged lymph node. It is important to see here that she is young, 20, and thyroid swelling and the lymph node. So it is a cancer. Which cancer is spread to lymphatic in the thyroid? Of course, all these are thyroid cancer. Which cancer occur in young first? 20.
Papillary cancer.
Papillary thyroid carcinoma occur in young, diagnosed or characterized by lymph node. Of course, under microscope, we have the famous orphan Annie cell, which is empty cell, and Sumoma body, which is macrocalcification. Okay. Next question is a 20 years old man with severe head injury is being ventilated using positive end expiratory pressure. It is important to know that the PEEP system or all this can increase the pressure, become positive, that affect the venous return. With the following physiological consequence for that. So again, this is PEEP system. So what happened to this patient?
Decrease
Of course,
preload.
Okay, so say again, decrease?
Cardiac preload.
Yes, so decrease cardiac preload. Okay, it is important to know that if the patient in PEEP system, they give the false high CVB. So if they found the patient have CVB 15 or 20, so it is on the ventilator. In the PEEP system, like ventilator have many type, we have intermittent ventilation and positive end expiratory ventilation. 70 years old man presented with 1 week history of epigastric pain, profound vomiting. Most likely consequence is, of course, if the patient, whatever the cause, like baby with hypertrophic pyloric stenosis, patient with peptic ulcer with fibrosis, patient with repeated vomiting or insertion of nasogastric tube for long time, they have something called metabolic alkalosis. This metabolic alkalosis can be associated with dehydration, associated with hypokalemia, and hypochloremia, the chlorine is decreased. Okay, so it's metabolic alkalosis. It's very important, can occur even in baby with hypertrophic pyloric stenosis. I will stop at 127, so just don't worry, we're about to finish. 22 years old man arrived to emergency with sudden breathing due to tension pneumothorax. Immediate chest drain is inserted, fifth left intercostal space, anterior to mid-axillary line. Nowadays, even needle, we put it in the fifth intercostal space anterior to the mid-axillary line. But by mistake, the tube inserted below the rib. It is important to know we insert the tube above the rib to avoid injury of something. So the patient have some hemorrhage. So which the following structure is most likely cause this hemorrhage? So it is injury of
Intercostal vessels.
Intercostal vessels.
yeah, intercostal vessels, vein, artery. Okay, of course we make it by mistake because it is must be above, not below the rib. Again, the common famous question common exam: the right left pulmonary artery derived from which of the following? And again, if the question come right left pulmonary, patent ductus arteriosus, both are arise from which arch? Very common question, consider as embryology
Sixth
question.
arch.
6 aortic arches. Arch, it is like pharyngeal arch. In fetal circulation, most of the blood passing to inferior vena cava into the right atrium, sequently pass next to which of the following? So, of course, in the baby or the fetal circulation, so we have a blood from inferior vena cava, go to the right atrium. After the right atrium is not go to the right ventricle because the right ventricle go to pulmonary and we don't have functional lung. So it is go to from right atrium to
Left atrium.
via and through
Fossa ovale.
fossa valve. This is if become patent, we called it what we called it atrial septal defect, ASD. Okay. Next question. 36 years old, butchers, injured left index with a knife, suffering from deep laceration of palmar aspect of the middle phalanx. On examination, unable to flex distal interpharyngeal. So the question again, which tendon? This is common question. Inserted in distal pharynx, and this tendon is flexor what?
Flexor digitorum profundus.
Flexor digitorum profundus. Yes, correct. Next question, 39 years old woman with large expanded ovarian mass that removed surgically. Require lateral pelvic wall excision, the lymph node. 4 days post-operative, she complained of painful spasm in the groin, remarked with the area of numbness in the middle side of her thigh. The most likely explanation this problem is during surgery injured what? It is important. Say again.
Genitofemoral nerve.
It is the medial side of the thigh. Medial side of the thigh, not the medial side of inguinal region. Genital femoral can be in this area of inguinal and just upper part of middle side of the thigh, but the rest of the thigh is supplied by branches from obturator, what's called here, obturator nerve. So the answer is obturator nerve. I found in the post of the in the other versions in the YouTube, they write the answer is genital branch of genitofemoral. But the correct answer is obturator. Because the genital branch of genitofemoral is mainly sensor. So they not affect the muscle, not cause spasm. So this is why we choose the obturator nerve. Okay. I think you see it in other versions. So this is why you answer genital branch of genitofemoral. Okay, or just by guessing. Okay, all right. Next question is a 70 years old patient is found to have sodium 125 normal on examination, no sign of hypovolemic. His plasma osmolarity 289 80, which is within normal, and the urine osmolarity 1000, which is normal. What's the following best explanation of this finding? So this patient have low sodium or slight low sodium, but osmolarity is okay. So what they have?
SIADH.
Yeah, it's syndrome of inappropriate antidiuretic cause salt to water retention and not affect osmolarity, not affected blood osmolarity, but make some dilution of the sodium, what we called it like diluted hyponatremia. The last question for today, so we can start next time by this. Surgeon is carrying out elective splenectomy for congenital spherocytosis, structure divided, mobilized the spleen from the posterior abdominal wall. So from posterior, what is the structure?
Renal ligament.
Okay. And also what other ligament, is this correct? What other ligament we need to cut between the stomach and the spleen? So gastrosplenic, because during this gastrosplenic we have the branch, what we call the short gastric branch, which is branch from left gastric. So it is important also to know that we have two ligaments. We start by lienorenal, followed by gastrosplenic. In lienorenal we don't have any structure, but in gastrosplenic we have short gastric arteries or vessels, so we need to ligate it. Okay. So I will stop here. So next time we continue. Next time will be